time zones and seasons, because we know there are so many countries, people from so many countries going to be joining us today. My name is Asti, and on behalf of the Center for Public Mental Health, University of Gajah Mada in Indonesia, and the whole of the team Together Mental Health Project from Ghana, Indonesia, and the UK, we welcome you to the online preview for the Together for Mental Health Project. Just a reminder for the general guidelines to everyone attending this virtual event. If you are joining us in Zoom meeting room, please be sure to mute your microphones throughout all of our sessions. If we have enough time, we will cater a question and answer session at the very end of all of the screenings and speakers' presentations. So please write down your question along with your name and institution and direct it to the host in the chat box. In addition to the Zoom forum, we are live streaming this event via YouTube through the Movie Ment YouTube channel. Please someone ensure that the link is provided in the chat box now for those of you who want it. And before we begin this event, let's take a moment of silence for prayers and reflections for our moment of togetherness here, but also for those who are struggling, particularly in this difficult time of the pandemic. We may start our silence. Thank you everyone for taking our moment of silence. And without further ado, let's begin our event by first introducing our Honorable Chair. The man who will be taking charge for the whole proceeding is the Honorable Dr. Roberto Mezina. For those of you who have yet to know him, Dr. Roberto is a clinical psychiatrist, as well as one of the world-renowned researchers in community psychiatry and global mental health. He is the former director of, pardon my pronunciation here, Dipartimento di Salute Mentale, or DSM, or the Department of Mental Health in the WHO's Collaborating Center for Research and Training in Trieste, Italy. He is also one of the strongest proponents for an empowerment issue for community-based care and multi-actors cooperation for mental health. So we are very, very thankful for his remarkable support throughout for our group here in Together for Mental Health, and as one of the great members of our international steering committee. We are grateful to also have benefited from your advice and support since the beginning of the project. And thank you so much for believing in us and also for bringing your spirit and positivity into our team. And I think my introduction cannot really explain the whole range of your work and contribution. So without taking much more time, please welcome Dr. Roberto Mezina. The forum is yours.
Thank you, Eddie, very much. I'm really honored to be here with you, and thank you for your very kind words. I'm just a retired psychiatrist at the moment, but I try to work anyway to go on with human rights and battle for improving also the recovery possibilities and opportunities for people with mental health issues all around the world. So I had the opportunity to work in Trieste, which is an experience probably well known, at least in the Western world, which closed first in Europe, the psychiatric hospital replaced with the community services. So that's why I'm very pleased to introduce this preview and discussion about research Together for Mental Health, where I'm honored to be part of the steering committee, and I think it's a great opportunity with this research to explore alternative views and other kind of cultures related to mental health, the possibility to investigate using participatory methods related to the experience of people, particularly those with the lived experience and their carers, which are struggling in countries where unfortunately there is not a high level of support by public services, and much of care is, the vast majority of care is relying still on traditional healers, which have a very important role anyway that should be understood and integrated in a wider vision, trying to change anyway the view of mental health issues, which are strictly linked to traditional views and sometimes leading to unfair violations of human rights, which are understandable in a context of limited resources, but related to them, it's possible to find alternative solutions. So the research is exploring what can happen in a place in rural areas, particularly in Ghana and Indonesia. And so investigating and involving local communities, and particularly people with lived experience. It's important also to underline that the research is looking into other views related to religion and the impact of religions, Muslim religion and also Islam and also Christian religion in those countries, particularly which are in a complex way interacting with local cultures and traditional ways of treating and trying to heal people with mental health problems. Also, it's important to underline that in both countries there are mental health reforms which have been undertaken recently, and also Ghana has been involved, as far as I know, in a very much important research and action through the World Health Organization, which is called Quality Rights Program, with the training of people with lived experience, carers, and mental health professionals. So the disability rights, the human rights, and the convention rights of persons with disabilities is one of the most important framework in order to overcome. But more than that and beyond that, I think the movies are showing the creativeness, the creativity of people in finding new solutions to those very hard problems and the way of facing and undertaking the complexity of lives of people suffering in those contexts. So I think the research is very important. We are going to look at a couple of preview of clips of the films done in Indonesia and in Ghana, and the preliminary findings also will be presented shortly. And then there will be a discussion, I think, and the involvement of all the people here. I have to introduce quickly the great team of the research here. Start with Lily Kbobi, sorry for my pronunciation, of course, which is a postdoctoral research fellow at the Department of Psychology, University of Ghana, working in the research. She has a background in clinical psychology and previous research experience with traditional and faith-based healing in Ghana. Diana Setiawati is the director of the Center for Public Mental Health at the Faculty of Psychology, University of Gadjah Mada in Indonesia. And she also studied in Australia, University of Melbourne, and she's been advocating intensely to various research and training for strengthening the mental health system in Indonesia, particularly with a multi-level, multi-factorial approach. Also, we have here Adi, that we heard already, Prastiani, which is a researcher in Indonesia, particularly at the Faculty of Psychology and Center for Public Mental Health, too, Faculty of Psychology at University that I mentioned before of Gadjah Mada. She's a medical doctor and also medical anthropology, which is a very important point of view, very valuable for the research. And she worked in a wide range of topics, which includes universal health coverage, tobacco control, human resources for health. Then we have Wulan Nur Yatmika, psychology graduate at the University of Gadjah Mada, a researcher in Indonesia. Ursula Reid from the UK, which is a research associate at the Department of Global Health and Social Medicine at the King's College in London, UK, and which was trained in occupational therapy and also in medical anthropology. She has conducted extensive ethnographic research on mental health, human rights, and social inclusion in Ghana, particularly since 2005, and is co-investigator of this research. Joseph Osafo is Associate Professor of Clinical and Health Psychology and Head of the Department of Psychology at University of Ghana, has been a lead investigator in various projects in the areas of mental health, suicidality, child health, maternal health, and is one of the co-investigators of Together for Mental Health project. Roberta Kekle Selormei is a clinical psychologist, graduate from the University of Ghana as research assistant in this research, and she's interested in treatment and care of vulnerable population. And last but not least, we have Erminia Colucci. Professor Erminia Colucci is Associated Professor in Visual and Cultural Psychology at the Middlesex University, London, and Honorary Senior Research Fellow in the Cultural and Global Mental Health Unit at the University of Melbourne. She's a clinical and community psychologist and visual anthropologist, and holds a PhD in cultural psychiatry. And I have to underline, she's very passionate about prevention of suicide, violations of human rights, domestic violence, and also she's using arts-based and visual methods in her research. She's the principal investigator of this fantastic research, and also filmmaker, so that can add a particular flavor to this academic activity. So this is the team. I think I have to stop here and leave the floor to particularly to Erminia, which was the last I mentioned. Thank you very much. Erminia, please.
Thank you so much, Roberto, for the lovely introduction. And as Asti mentioned, it's fantastic having you here sharing this event. Thank you for all your support for this project, also to be a good example about what we're aiming to do within our own work. So thank you so much. It's a very honor to have you here. And thank you to all of you who are taking part in this preview event. We are very excited. We've been texting each other since last night in full excitement. Our first preview event. So forgive us if there is anything that doesn't go fully as we planned, but you know, we're doing our best. We are super happy to be able to finally share with you some of our findings and some part of our films. I'm gonna be sharing my screen now, or try to give you an introduction about our project. Can you see my screen? Okay. If not, please let me know. Okay. So as you can see, our project is, as Roberto said, is called Together for Mental Health, and it's about using collaborative visual research methods to understand the experience of mental illness, coercion, and restraint in Ghana and Indonesia. We actually have to press this. So, and if you want to tag us throughout this event in the future, our hashtag for all our social media is Together for MH. Now, I want to just very quickly cover about what actually, why we're doing this project, how we're doing it, and what we're aiming to achieve, which also was mentioned already from Roberto before. So as many of you will know, in the past decade, human rights abuses of people with mental health issues in low-income countries have been increasingly reported in many countries, including in Ghana and Indonesia. Now, both in Ghana and Indonesia have passed law begging the use of physical restraint on people with mental health problems. However, we know coercion practices remain unfortunately very commonplace, and mental health workers face resource challenges in carrying out community-based intervention. Now, in addition to this, despite some increased availability of mental health services, in both contexts, the traditional, religious, and spiritual practices remain highly valued in addressing mental health issues. Now, it has been suggested a partnership between traditional and faith-based healers and health workers could prevent human rights abuses against persons with mental health issues and enable access to treatment and better mental health care. But although there has been long-standing calls for collaboration, there has been very little investigation about how such relationship will work in practice and how to best create effective partnership between mental health workers and healers in specific locations with the differing healing traditions and with different mental health systems. So our very small to achieve aim is to explore attempts made by mental health professionals, workers, and to establish collaboration with faith-based and traditional healers, exactly for preventing the use of coercion and provide care for persons experiencing mental health illness. mental health. So our specific objectives are three. First of all, is about exploring and documenting social, cultural, economic, and structural factors that influence responses to mental illness, in particular about decisions to use coercion and restraint. Then also exploring and documenting lived experience of mental illness and coercion and restraint, and also mental health workers and healers' attempts to collaborate to prevent the use of these measures. Our second objective is to co-develop advocacy activities and capacity building tools to prevent coercion and restraint and improving mental health care. And lastly, also developing a global south-to-south network with the idea of sharing experiences and best practices to reduce use of coercion and restraint and improving mental health care. And we are very excited to see that many of you join us from different countries, and we hope this preview event today will be also an opportunity for us all to connect together and be part of this network. So we are very much looking forward to potentially working with many of you in achieving these aims and these objectives. Now, going about the how we're going to achieve this, this is an applied interdisciplinary, representing, in fact, how the interdisciplinary our team is, visual research project based on two particular methods, participatory methods and ethnographic films, both in Ghana and Indonesia. And we chose to use the visual methods because they can be very effective tools to raise awareness of mental health as well as human rights and advocating for change, which is ultimately what we want to do with this project. In terms of ethnographic documentary, we have filmed field observation and interviews with people experiencing mental illness and coercion and restraint, family carers, healers, mental health workers, and other key stakeholders. We asked for a staged consent to be able to observe, but also film the person while they're engaging in their daily activities, including also religious services, other kind of healing practices. And the reason why we wanted to use also this kind of documentary is because it gives access to subjective experiences without forcing any explanation. And it can be a very valuable method for exploring ethically complex and multi-layered topics, such as the one we are embracing with this project. Then in terms of ethics, I'm not going to go very in depth, but obviously the ethics was very important in this project. And we used a kind of a staged consent process where people were given a quite complicated consent form, which was translated and read by our research assistants to be able to indicate exactly which kind of level of confidentiality and anonymity they wanted to keep. And also they could revise the decision about what to disclose about themselves and their location and what not to disclose could also be changed if they were interviewed or if they were followed in multiple occasions. Now, this was about ethnographic filmmaking, which was in Ghana, Indonesia. We were lucky to be able just in time to complete the data collection, and then we moved on to doing participatory visual methods. Again, giving a very short introduction, given our little time. The method we used is a participatory video, which basically is a set of techniques aimed to involve a group or community in shaping and creating their own film. In this case, participants, which we call storyteller, produce their own film or films based on the issue that matter to them. And also, again, they have complete control about how they will be represented. And as for the ethnographic documentary, also in this case, we chose this method because it is a very powerful means of documenting and sharing local people's experiences, their needs, as well as the hope from their own perspective, something which was very important for all of us in this project. Now, we were able to complete a participatory video workshop in Indonesia, where we worked with 10 students of Atmajaya Catholic University, as well as 11 members of our partner organization, KPCI. We did a 2 days workshop, and then after a couple of months of working on the film, the students and the KPCI members showed the film at a short film festival in Jakarta. Now, when we were ready to go to Ghana, literally the week we were leaving to go in Ghana and doing the same workshop, kind of workshop, training filmmakers, local filmmakers, actually in this case, to work with people with experience. Unfortunately, COVID restrictions were put in place. So we are unable to go to Ghana, but we are very hopeful 2021 will be a different year, or at least we'll be able to travel more safely. And we are hoping to be able to complete this last part of our data collection and research in Ghana. So hopefully we'll be able to show you more films in the future. Now, this project has different kind of components, different kind of outputs. As I already mentioned, the two ones just mentioned were ethnographic documentary film accompanied by an educational screening guide, as well as short participatory videos and digital stories, scientific publication in peer-reviewed journals, but also training materials and case studies about how can we use these kind of methodologies, particularly working with people with mental illness in low and middle-income countries. Also seminar, webinars, lectures, academic presentation, but also visual and written teaching materials for undergraduate psychology students in different disciplines. So many things to do, and we are starting showing some of them to you today. And what we're hoping to achieve with all these outputs is to provide evidence on the use of restraint and coercion for people with mental illness and the barriers and facilitators to collaboration between healers and mental health workers. Now, we believe this can be of use in implementation of mental health policies and practices that aim to prevent human rights abuses in this country. However, we also believe that the project outputs can also be relevant for other countries with similar practices of coercion and restraint and use of traditional faith-based healers, and therefore can also be used for public engagement, advocacy activities, teaching, capacity building in mental health in these countries too. Now, I think it's our first event, so we are beginning. You are part of this journey with us. So if you want to follow what we are doing, what we're achieving, if you want to contribute to what we're aiming to achieve, please join our blog movement so you can receive updates about any events. You can also follow us in Facebook, Instagram, Twitter, again, using the hashtag Together for MH, as well as our YouTube channel. So we hope to see many of you through these vehicles. And now, before I close and give the words to Diana to speak about Indonesia, and then I can finally introduce you all to some section of our films and some preliminary findings. There are a lot of things we have to say. We can cover everybody, but I want to make sure that we are acknowledging, to begin with, our funding body, which is UK Economic and Social Research Council Global Challenges Research Fund. Also, our institution, Middlesex University London, University of Ghana, Universitas Gadjah Mada, King's College London, and our very important project partners, as mentioned already, Indonesia Community Care for Schizophrenia, Mind Freedom Ghana, BEMP Intertenane, and Nubuga Foundation. Also, very big thanks to our advisory groups in Ghana and Indonesia, our steering committee members who are so important in this project, giving us support of different kind to what has been not a very easy project, also not only for the topic, but also because of the COVID disruption. Our special thanks go in particular to our steering committee chair, Professor Leslie Schwartz, who I hope is with us today, and again, to Roberto Mezzina, our beloved member, who is very kindly chairing our preview event today. So thank you again, grazie ancora, Roberto. Also, a very big thank you to our very committed and very patient editors, Nadia Stario from Indonesia and Anthony Comber-Badu for Ghana, and a very, very deep thank you to all the people who lived the experience of mental health conditions, their family, who so generously have shared their stories with us. Also, to going to more country-specific acknowledgement in Indonesia, big thank you to Mental Health Directorate, Ministry of Health, Republic of Indonesia, Faculty of Psychology at Madjaya Catholic University, Jakarta, also our participant in Cianjur, Pondok Nurani Kemanusiaan Foundation in Yogyakarta, BRH Rukia Center, Al Islami Foundation, Nurul Aromayan Islamic Boarding School, in Bali, Suryani Institute for Mental Health Foundation, Rumah Badaya Community, PSN and Gases Bali Foundations, and finally in Flores, Rencheng Mose Rehabilitation Center and Communion Order of the Catholic Church. And then finally, also big thank you to staff affiliates of the Center for Public Mental Health, University of Gadjah Mada, for transcription, translation, graphic, and many other kind of assistance and endless support. Thank you so much to all of you. And now moving to Ghana. Also, big thank you to Dr. Akwasi Osei, Madame Priscilla Tawia at the Mental Health Authority in Ghana, the Ghana Health Service, Dr. Damian Pungure, mental health workers in Bono East region, particularly George Osei, Abu Member Imunikema, and their fantastic teams. The healers and church leaders, the congregations, particularly Nana Numufye, Nana Duodu, Prophet Kozu, and the Holy Healings Church, and Kansa Prophet Owusu, Elder Owusu Mensa, the Reformed Christian Apostle Church in Teteshman, Prophetess Teresa Popime, and the blood of Jesus Christ, Tobobam, Elder Elia Yeman, who unfortunately deceased, and Mount Zion prayer camp. And then also our thanks to the workers at Peace of Christ, Operation Hand in Hand, for hosting a feeding team during the fieldwork. Very, very important task. And also before I close, I want to just personally give a super, super big thank you to this fantastic team in UK, Ghana, Indonesia, for all they've been doing. All of you will be shortly be seeing some of the film footage, hearing some of the results from the study, and you will see with your own eyes and hear all the passion, the compassion, and the commitment to improve mental health care and eradicate human rights abuses against people with mental health issues. So thank you to you all. Now the word to you, Diana.
Thank you, Amy. Asti, please. Hello?
Yes, Ibu. And yes, thank you, Armenia, for the introduction. And we are going to start our presentation from Indonesia by showing you two videos. The first will be a 12-minute excerpt from our film Rough Cut, and the second will be a 5-minute short film that was produced from a collaboration between Together for Mental Health, Atmajaya Catholic University, and the Jakarta chapter of the Indonesian Community Care for Schizophrenia, KPSI. And following that, our Indonesian co-investigator, our very own director of the Center for Public Mental Health, the University of Gadjah Mada, Ibu Diana Setiawati, PhD, who will present an overview about the work in Indonesia and a little about our emerging findings. So let's first enjoy an excerpt for our film Rough Cut, with special thanks to our amazing editor, Nadia Astari. Ibu Diana, you.
Okay, hang on. Hang on. No, not yet.
For those in the audience who might have a little difficulty streaming with Zoom, you can also enjoy the film excerpt from this link in Wistia.
Have you seen my screen, Mbak Asti? Not yet?
Not yet, Ibu.
Hang on, yeah. Where is the Zoom? Hang on, I need to, sorry. Where is this? Okay, I think there is something. Hang on, okay. Now, can you see now?
Not yet, Ibu.
Not yet, okay. Hang on. Sorry.
Yes, you can start now, Ibu.
Yeah, can you see?
Yes.
Yeah. Okay.
Not yet, Ibu. Can you?
Oh, not yet. Okay. Hang on. I don't know. Sorry for a bit technical problem. Hang on. Please bear with me. I think now you can see soon. How about now? Can you see?
Yes.
How about, yeah.
saya mempelajari, hampir semua orang percaya kita mempunyai roh. Sehingga kita itu bisa memahami orang, tidak harus melihatnya, tapi merasakan energi pun bisa. Dan dari sini kita bisa melihat bahwa pasien tidak selalu harus ditangani secara fisik, secara mental, tetapi juga dengan pendekatan spiritual ini.
Sebenarnya tidak bisa dipungkiri bahwa pasien-pasien di gangguan jiwa ini sangat lekat dengan pengobat tradisional. Biasanya pasien itu akan bertanya ketika kita menjalani sesi-sesi terapi, dok, boleh nggak kami ruqyah misalnya. Biasanya saya memotivasinya begini, wong sakit fisik saja, orang dengan penyakit fisik saja mendapatkan doa, mendapatkan dukungan ya spiritual, itu saja akan baik gitu. Tapi tetap sesi-sesi terapi kita jalani. Kalau pasien membutuhkan obat juga obat tetap diminum rutin. Nah, ketika ketemu dengan kiai atau peruqyah, ini doa-doa, zikir dan sebagainya itu pasti akan menguatkan gitu. Nah, biasanya kalau sudah saya menyampaikan bahwa tidak pernah ada yang melarang ruqyah ya dan sebagainya, pasien akan tanya, siapa ya dok itu di antara yang mungkin dokter tahu gitu, yang dokter rekomendasikan. Kebetulan Ustadz Fadlan salah satu yang saya kenal, saya pernah berdialog lah dengan beliau ya, jadi paling tidak sudah jadi lebih paham karena beberapa kali pernah diskusi gitu.
أعوذ بالله السميع العليم من الشيطان الرجيم آتنا وتوفنا مع الأبرار ربنا وآتنا ما وعدتنا على رسلك ولا تخزنا يوم القيامة سميع الدعاء اللهم لك الحمد حمدا كثيرا طيبا مباركا فيه وكما وبارك وسلم والحمد لله رب العالمين Amin, amin. What are you feeling?
Gimana rasanya sekarang?
Lebih lega.
Ya?
Lebih lega.
Semua penyakit tekanan batin mempengaruhi orang lain. Maka berdoalah meminta ketenangan itu.
Memang seperti dengan tombo-tombo one tilu lihat tombo-tombo tidak bisa tidur ngaji lihat reveng itu tombo-tombo itu. Jadi supaya bisa kendalikan. Biasanya langsung vale-vale atau tombo-tombo ya. Sentuhan, touching itu membantu. Rupanya mungkin saraf-saraf, saya juga tidak tahu, saya tidak bisa. Tapi ini misteri, saya merasa bahwa sentuhan itu membantu. Touch, kasih, di situ saya merasa bahwa kasih Tuhan pakai tangan saya untuk mendoakan mereka. Tuhan Yesus, Engkau menumpangkan tangan dan berkat-Mu mengalir atas putrimu ini. Ketika saya percaya bahwa kekuatan penyembuhan dari atas terjadi, biasanya saya katakan, oke, ini bisa sampai di sini, tapi kalau makin berat saya dalam nama Bapa dan Amin.
Terima jauhlah kami dari bahaya, perang, penyakit, dan segala kejahatan.
Pandangan mereka bahwa saya akan sembuh dengan berdoa, dengan melakukan acara-acara dan adat-adat spiritual. Jika terlalu tinggi, kita akan susah masuk untuk bicara tentang gejala skizofrenia, obat ini bisa membuat pasien ini stabil, itu mereka tidak percaya. Harus ada medium antara yang spiritual dengan yang medis. Di antara itu tuh yang kami butuhkan itu adalah para medium ini, para pastor, para pendoa, para dukun, para orang pintar di kampung-kampung, para tokoh agama, datang ke kami bersama dengan pasien, supaya kita bisa diskusi.
Menurut pemahaman si Ajengan itu bahwa di diri saya itu ada jin. Nah dari situ saya tuh diruqyah. Semua santri dan ustadz duduk melingkar dan saya di tengah-tengah dan mereka ngaji untuk saya supaya si jin di dalam tubuh saya itu menghilang. 2 minggu berobat di situ tapi nggak sembuh-sembuh. Nah, ustadz-ustadz itu mereka bingung, ini penyakit apa? Dan akhirnya si ustadz itu minta bantuan ke pihak Yayasan KSC.
Ada khas yang kami lakukan di sini adalah satu sama lain itu semua harus saling membantu. Kakak ngasuh adik, sesama ODGJ. Tidak ada di sini perawat profesional, boleh dicek. Tidak ada dokter yang khusus setiap hari standby mengawasi. Tidak ada. Merawat ODGJ adalah oleh ODGJ itu sendiri. Ini rumah keluarga.
Saya ingin mencoba pendekatan yang berbeda bahwa sebenarnya ini tergantung kliennya, klien center kan. Jadi kalau dia mempercayai itu saya berusaha menggiringnya pada hal yang ramah juga. Apalagi syukur-syukur membantu untuk penyembuhannya. Tapi kalau dia tidak percaya ya tentu saya tidak menyarankan. Jadi sebenarnya sesimpel itu. Saya bukan orang, jadi soal saya kan tidak penting. Soal terapisnya atau pemahaman kepercayaan terapisnya kan tidak penting. Ketika Tiang ketemu dengan dia pertama kali, sudah melihat pikiran dan lain sebagainya menerawang. Apa yang bisa Tiang lakukan? Komunikasi yang pertama. Tiang ajak ngomong sehingga Tiang masuk pelan-pelan ke kehidupannya dia. Ternyata di sana ada beban psikologis yang dialami. Tadi sebenarnya itu sebuah prosesi upacara ritual, tetapi bahasa kerennya hipnotis, supaya pikiran di bawah sadarnya, keluh kesah yang ada dalam dirinya, dia luangkan dalam luapan emosi tersebut. Kita tidak bisa berbicara di skala aja tanpa bantuan skala. Oleh sebab itu, Tiang bersihkan dulu nih loh. Tiang lukat dia, Tiang mandikan dia dengan air suci dan lain sebagainya. Setelah ini berlangsung, Tiang lihat sudah aura, cakra atau dalam dirinya itu sudah mulai membaik. Baru Tiang akan ketemukan dengan dokter psikolog. Salah satunya adalah dokter Rai.
Lumayan keras. Sudah tahu beres. Bisa jalan dok. Serok. Sabar.
ya. Tunduk. Rumah baru. Kita ngaji. Utuslah Romo yang kudus Tuhan, barulah tubuhnya, jiwanya, dan ruhnya. Ampunilah segala dosa dan kesalahannya. Sekiranya ada kejahatan atau kuasa gelapan yang menimpa dia, semoga Romo yang kudus menghalau dan menghancurkan kejahatan itu, dan tangan yang maha kuasa membebaskan hamba ini dari segala kejahatan dan kuasa kegelapan. Dalam Bapa dan Putra dan Roh Kudus. Semoga Tuhan beserta kita. Mau makan kue, pisang goreng atau apa? Mana mamanya tadi? Mama, sini.
Naik. Memang sih yang keluarga di dalam rumah. Ini neneknya.
Terima kasih kepada Ibu Perawat nih. Ya sudah membantu pendamping obatnya.
Kami juga berterima kasih karena keluarga yang kami layani juga bekerja sama dengan baik.
Okay, that's the first movie. And this one is the participatory movie. Can you see now? Yeah. But Asti, can you see the?
Yes.
Awalnya saya rasakan ketika saya kuliah di salah satu perguruan tinggi negeri di Sumatera Barat, di Fakultas Sastra jurusan Sastra Indonesia. Saat menjelang ujian akhir semester 3, timbul suara aneh, seperti suara yang mengajak bicara, menakut-nakuti, menghina, dan mengejek saya. Hal tersebut menyebabkan saya mengalami kemunduran dalam belajar. Pikiran saya sibuk memikirkan suara aneh yang menimbulkan perasaan saya terganggu. Saya mempunyai cita-cita kumlot, namun karena suara-suara aneh muncul menyebabkan pikiran saya tidak dapat fokus belajar untuk mengikuti ujian akhir semester. Hal tersebut membuat pikiran saya tambah kacau balau. Saya bertemu dengan orang pintar yang sudah tua. Saya disembur air ke muka saya, dibacakan mantra, dan diberikan jimat untuk diletakkan di bantal saat saya tidur. Namun, saya semakin parah. Suara-suara aneh semakin terdengar jelas. Suara itu terus mengejek saya dan sangat mengganggu saya, sehingga saya tidak dapat belajar. Hal itu menyebabkan saya memutuskan untuk tidak mengikuti ujian. Akhirnya, saya disarankan untuk berkonsultasi ke psikiater. Saya bercerita apa yang saya pikirkan dan rasakan. Psikiater menyuruh saya untuk mengikuti ujian dan memberikan saya obat untuk menenangkan pikiran dan kecemasan saya. Namun saya tidak bisa menjawab soal-soal dengan baik, karena memang saya tidak dapat belajar dengan maksimal. Hal itu menyebabkan saya stres berat dan putus asa bercampur kecewa dengan diri sendiri. Nilai IPK saya jelek. Saya depresi memikirkan nilai saya. Saya yakin cita-cita saya untuk menjadi guru besar sudah kandas. Saya frustasi dan memutuskan untuk cuti kuliah dan berobat pulang ke Jakarta. Orang tua saya pun membawa saya berobat di rumah sakit terbesar di Jakarta. Psikiater pun menjelaskan ke orang tua saya tentang semua yang saya alami dan faktor pendorong penyakit saya timbul. Dokter memberi obat dan saya harus minum obat secara rutin selama 2 tahun agar saya dapat sembuh total. Saya minum obat hanya beberapa hari saja karena merasa sudah sehat. Namun penyakit saya bertambah parah. Perilaku saya semakin aneh, sering marah-marah, ngamuk, kadang ketakutan tidak jelas, merasa dihantui sesuatu yang menyeramkan dan aneh-aneh. Saya tidak berani keluar rumah bertemu orang banyak. Kondisi kesehatan saya semakin parah, badan semakin kurus, tidak mau makan. Hal ini karena saya mendengar suara yang meyakinkan saya bahwa makanan dan obat yang diberikan dapat meracuni dan bertujuan membunuh saya. Saya selalu marah-marah kalau dikasih obat dari psikiater. Orang tua saya pun berusaha memberi obat melalui makanan dan minuman. Usaha orang tua saya membuahkan hasil. Kondisi kesehatan saya mulai membaik. Keluarga memutuskan saya dirawat inap di Rumah Sakit Umum Pemerintah di Yogyakarta. Kebetulan salah satu kakak saya tinggal dan bekerja di Jogja. Jadi ada yang mengurus saya selain ibu saya. Di rumah sakit itulah saya sadar akan pentingnya minum obat bagi penderita skizofrenia setelah saya membaca buku di perpustakaan rumah sakit. Buku tersebut menjelaskan mengenai ODS dan benar-benar mirip dengan apa yang saya alami. Beberapa minggu kemudian, saya sudah bisa rawat jalan dan pulang ke rumah. Kondisi kesehatan saya semakin membaik. Namun saya tidak boleh terlalu letih dan capek karena dapat menyebabkan saya relapse. Sekarang saya mulai mengisi hari-hari saya dengan membantu orang tua saya mengerjakan pekerjaan rumah. Dan saya bekerja menjadi guru homeschooling untuk Calistung, anak kelas 2 dan kelas 3. Saya sekarang rutin kontrol ke psikiater dan teratur minum obat. Semua orang-orang terdekat saya, termasuk keluarga, mendukung pengobatan saya untuk berobat ke psikiater. Saya senang dengan pekerjaan saya sekarang. Saya belajar untuk tidak terlalu mengkhawatirkan yang belum terjadi dan lebih mendekatkan diri kepada Allah. Menurut saya, kepatuhan minum obat dan kontrol dengan psikiater sangat penting dan sangat dibutuhkan ODS agar bisa pulih. Selain itu, peranan keluarga sangat penting untuk memberikan dorongan dan kepedulian terhadap ODS.
Yes, and that was the short participatory film co-produced by Stephanie, a psychology student from Atmajaya Catholic University, and Siti Anissa, a member of the KPSI Jakarta, titled My Pain Schizophrenia, and you can watch it in YouTube. And with special thanks to Ibu Angela Octavia Suryani, the Dean of Faculty of Psychology at Atmajaya, and Mrs. Nini Supartini for co-facilitating the workshop as well. And back to you, Ibu Diana.
Okay. Thank you, Asti. So that's the excerpt. Yeah, of course, it is very hard for us to choose which one of the footage that we want to show, because everything just very precious. So this is the Indonesia for those who don't really familiar with, and this one is the place where we did the research in Cianjur. Cianjur is just close to Jakarta, and Jakarta is our capital city. And this one, the second one is Jakarta. Jakarta is where Universitas Gadjah Mada cited. Yeah, and then this one is Bali. Maybe you know Bali very well. Yeah, more than Indonesia. This is here, and then the fourth one is Nusa Tenggara Timur, East Nusa Tenggara or Flores. This one, and the island names Flores. So, and other than that, we did a participatory video workshop in collaboration with Catholic University Atmajaya Jakarta, and the participants. Just now, I saw you one of the participatory video, and from West Java, the case study, first case study from West Java is that you saw in the movie, Mr. N, late 50s, a family member and caregiver to her niece living with schizophrenia, took the initiative after learning about horrible treatment such as pasung from other psychiatric patients. So from 2015, self-led residential care facility using donation by a local Islamic charity group who conduct visits periodically. Yeah, and also currently you saw in the movie that they have what they call family home. No professional nurse inside the care, just people living with schizophrenia caring the other, something like that. This one, yeah, you saw in the movie. This one is the West Java, Cianjur. They care each other. And then the second case is from Yogyakarta, Bantul. There is a Ruqyah clinic founded by Ustadz F, part of the Indonesian Ruqyah Association. He was the head of Indonesian Ruqyah Association. The practice is not focused on mental health cases, so focus on everything, but sometimes received by client referred to him by mental health care professional. So he has a connection with the psychiatrist in the movie, and sometimes they refer each other patient. And then the other case is from Yogyakarta, Kulon Progo. There is a pesantren that has always been started as a rehabilitation facility for people with severe mental illness, including drug addiction. Started as a facility oriented more to Islamic healing methods, it evolved into an integrated facility because they are the children of the owners, maybe 4 of them become a medical doctor. Then since then, they become a more integrated between medical and Islamic healing. So this is the place where the pesantren. And then the fourth case is from Yogyakarta. This one is close each other. Yeah, originally a pesantren or Islamic school, very big, founded by an Islamic cleric, gained reputation to successfully care for a student with mental health condition. It started to be place of referral, develop personal and working relationship with one of the state of mental hospital located in a nearby city close. So they have regular travel for patient, yeah, for patient that living there to go to the hospital to for regular seeing the psychiatrist. It is where it is. And then next we went to Bali, Denpasar. The fifth case study is a network of medical, psychological, and faith-based healers, very, very nice, involved in various degrees of collaboration for mental health issues. Dr. R, a young psychiatrist, pioneered a peer support gathering of people living with severe mental illness, introduced and connected to local Hindu religious leaders, introduced mental health perspective for future religious leaders. And then Mangkudi is a progressive young Hindu religious leader, regularly hold training for young aspiring religious leaders, has experience living with mental illness, also runs and leads religious rituals. And then Dr. K, a scholar of Balinese Hindu culture, a religious leader, leads a performing and visual art community for religious ritual services. Also receive people for consultation. Dr. D, clinical transpersonal psychologist. This is the other psychologist other than Dr. K, and provide spiritual healing. So this is a very nice collaboration between psychiatrists, cultural expert, and also the culture leaders, and then and then the psychiatrists, psychologists. The sixth case study from Bali is Prof. S, very senior psychiatrist, combine her psychiatric practice with her brand of approach to spirituality. You saw the meditation in the movie. Yeah, and then we move to Flores, Ruteng, Manggarai. The 7 case studies from RM is a residential rehabilitation care for mental illness started by the Caritas Order of the Roman Catholic Church. Dr. RS, young general practitioner born and raised in Manggarai, with experience practicing in a Jakarta mental hospital, head of the facility. And then Brother H, Brother J, Indonesians, brother of the Caritas Order, trained in psychiatric nursing in Belgium. So become a psychiatric nurse, taking care of them in the residential rehabilitation care for mental illness in Manggarai. This is the, this the place where. And then the 7 case studies from Maumere, Sika, so it is a bit farther east, Chameleon Order, a special mission for healthcare. Father Al and Father An, Indonesian Chameleon priest, running a seminary, networking with local health professional, initiative for Pasung release, making safe house. You saw in the movie just now that there is a small house that very secure, and they make it to free people from Pasung and put this in the safe house like that, like this one, the safe house. And the preliminary themes that we gathered from the data analysis is that form of collaboration between the spiritual healer and mental health system or mental health professional is embodiment of integrated approach in person, referral relationship, direction of referral, has system or outreach, filtering, negotiating of approach. And then the second theme is facilitating factors to collaboration is mutual recognition of roles, negotiation and compromise, equality view, networking and leadership, differentiation between spiritual experience and mental health symptom. And we surprised that some of spiritual healers understand that very well. And then transition phase, cognitive resonance. And then the third theme is symbolism of healing, symbolic interaction with rituals, and symbolic interaction with water across the faith. That's very interesting. Okay, that's the preliminary result from our research in Indonesia. Thank you very much. Maybe I return to Roberto.
Okay, thank you very much. It was fantastic. I think this very much in depth. So thank you for the team in Indonesia. Now it's time to introduce Ghana film clip and summary of the preliminary findings. So Lily, I think Lily will talk about it. Please, Lily.
Hello, everybody. Thank you for joining us. It's really exciting for all of us to have you see the fruits of our labor the last couple of years. We will show a little clip of the Ghana film, the rough cuts that we've got so far. As Erminia explained, we haven't been able to do the participatory videos quite yet because of the COVID situation, but we will discuss a little bit about what the next steps are also later and give the chance for some suggestions as well. So I would hand over to Ursula now for her to share the screen for the film, and then I'll come back in and summarize some of our findings. Enjoy.
Thank you, Lily. Yes, okay, so we are going to hope that we have that the system works okay. Just opening. Okay, so I'm going to share my screen shortly. I will also paste the YouTube link so that in case of any difficulties, we can you can watch it there. So I'll just copy that into the chat. So if there's any difficulty, please, you can also see it here. So I'm going to share my screen now and hopefully it will work. Okay.
Mm-hmm.
Can everybody see my screen okay? Yeah.
Yeah.
Since you're not many, this is how we work. So anytime there's a case, normally because I'll make sure that every month, at least every month, I go around and we have established rapport with them. The mental authority and the regional protector center organize workshop for such people. So because of this, we have good collaboration with them. Anytime they have a case, they ask the judge, this is not happening. So where should this person go? And this is the program. So we give the direction, or go to health center or go to St. Joseph's. And one thing is we try to communicate the feedback to them.
So let Derek, you go in the back, have a bike ride. Let someone join you. Okay. So we'll start reporting this today. So are we ready? We have number of prayer camps and faith-based centers in Techiman Municipal. Number of them, if I would say about 5 of them, and then 2 of them are inactive. So we basically had 2, Reformed Christian Apostolic Church, and then the other one, Continuation Church. When it started is when about 3 years ago that the collaboration started becoming strong. They allowed us to come here as part of our outreach activities. And then they do bring, all of a sudden, they do bring their patient to our outreach for treatment. So we do come, we give treatment here. Sometimes we do even see acute cases here. Now we had a special arrangement with the social welfare and the municipal health directorate. We had names of those patients they see with that insurance. Then they were all insured for free as indigent. It was positive for us. I think that was the way forward that we started collaborating with them. What hospital happened? Oh, mommy, and I told you, I said, I will not have a from.
Say, Osha, you know, my say, man, I check. Now, said they started and say, you say, in fact, young one in India and so be a real bra. Nipa be a war, I've been with it. It will be now, doctors no war, India was so. Then the yeah, home from the let's say 20 from my own bear from them from a deal. For who are now, untimidity. And the other would just anybody what the fear is that only the phone or from. Doctor, but which much was a quantity in the password, which meditate. Now, quantity the password, which may add that our own hardware. Quantity in the password, A be a variable call. In I idea, this happened in the free doctors and saying.
At many go her, the bar, which means their nurses when you near hospital side. A bus I'm a moment in a more. You want to change the council, the lady, and you know what you call. She be at me. If you may invite you, no more, but no more. I hear in natures of market. If you are now over the Denpasar, you mean to be in a hospital. This one in your hospital alive. It's because if you're in a couple, Mark and one still in eternity. To be an spiritual idea, and you praise now, dear 90 years. In fact, my child from 36 years. And then France say, Mr. Tedman, be back up. Be back, be so only down here, no, my dear. Can you know who is family? And I mean, that one. Actually, helpful for buy and just say, family. And no more advice in this. You are not helpful. You will family for the advice and call. In the end, so one quite young and you say, one quite young in 3 years. In the mood and advice you, the more that into I see the bus and Masuma. We do so. I support to prayers. Not a 2 years.
Yene asofo ne traditionalists no dika mudiana aye akonkan aye successful but nyina no maybe kwa me fa so me hu success in different from kwa so hu de but obia o ne hu be ma okwan mo bani premises said ya me ye me ne wonye mu obama okwan mo tre je ne pocket say for educate microphone that one alone tells you say is willing to work with you. And no one method fashion is successful because we have been working hand in hand with that.
Not something before as the real as the actually, for the must see the Kenya, no, you are not Woman, you must ask her can be. And now that Ochina, or what can I say about the say, let's get a bit. You must say, I got to get to this. Amen.
Apologies for muting. I didn't how that happened, sorry. But as Minia said, you can watch it again on their YouTube. Apologies for that.
Okay, thank you so much, Aisada. Yes, the video, there was a bit of a delay, as Aminia has explained, but then it is available for you to watch on YouTube and at the links that have been provided in the chat. So if you're interested in seeing it again and again, we hope, please check out the links in the tab. Okay, I'm just going to share my screen now so that I can briefly talk about the preliminary findings that we had from this end of the project. Can you see my screen? Yes. Okay, great. Thank you. So I'm just going to first give a brief background on the Mental Health Act in Ghana, or generally about the project and why we were interested in this part of or this type of project. For those who are not aware, Ghana quite recently in 2012 introduced a new Mental Health Act. After decades, I should say, of negotiations and discussions and maybe a lot of wrangling in Parliament, we finally managed to get a new Mental Health Act passed in 2012, which, among other things, was looking at ways to scale up and to improve mental health care across the country in different ways. And one of the things that was expected or provided for through the Act was the establishment of a mental health authority, which would be responsible for mental health activities in the country, including regulation, including training and all those other kinds of things. So one aspect of the work that the authority does is to work together with non-biomedical practitioners. For instance, Section 3 of the Act talks about collaborating with the Traditional and Alternative Medicine Council so that they could provide optimum care or ensure the best interest of persons who are living with mental health experiences. So the Mental Health Authority has been committed to working with what we loosely would term traditional healers. It encompasses a number of kinds of healers, but generally we tend to talk about them as traditional and faith-based healers. And one of the ways that they have started to work together with these healers is through collaborations. Now, some guidelines were developed for traditional and faith-based healers and how their work could fit into the expectations or the provisions of the new Act. And in particular, things like ensuring that there's a minimization and eventual absence of human rights abuses for people who seek care in alternative health places, including the biomedical, but also in alternative healthcare facilities. They're committed to ensuring that those kinds of human rights abuses are reduced. Before this new Act, there was quite very little regulation of the work of non-biomedical healers. It was difficult to sort of streamline or integrate what they were doing. So the Mental Health Authority has been interested in formalizing the work of the authority in collaboration with the Traditional and Alternative Medicine Council, but also in providing guidelines for best practice. And one of the ways they try to work together with them is through using a register of activities when the nurses go out there. So there's a collaboration between formal mental health workers and traditional and alternative healthcare providers in the different regions. Just to give a little bit of background about the research setting where the filming was done, We filmed in the Bono East region of Ghana. Sorry, I should have provided a map. It didn't occur to me that some people may not know where that is, but it's located in the center of the country, almost smack in the center of Ghana. We worked with the teams in two of the municipalities, the Nkranza South Municipal Mental Health Unit, and then the Techiman Polyclinic, the mental health units that worked over there. So these two teams were the ones that we worked with for them, and they showed us what their activities have been like in terms of the collaboration that they have with the healers. An aspect of the background of the research setting is important to notice that there are very few mental health professionals in that region. It is the case in much of the country, much of Ghana, but for this particular region, for instance, one of our participants explained to us that the ratio of mental health professionals to the population is 1 person to 120,000 in the population. So there's a real dire need. The numbers are large, or they are few rather. The number of professionals are few, and they do not have a dedicated psychiatrist at the moment. There are some physician assistants in psychiatry quite recently. There are, of course, mental health nurses and community mental health officers and other kinds of professionals, but the needs versus what is available, there's still quite a large margin. And so they have been distributed in various health centers within the communities in those districts or in those municipalities in order to serve smaller clusters of communities throughout the municipality or throughout the districts. These mental health nurses or the workers, the community mental health workers are the ones who are largely responsible for starting up, negotiating and building on or strengthening the collaboration with the non-biomedical providers. So we have seen collaboration with Pentecostal churches and then also traditional shrines with the healers who provide mental health services in these places. Okay, so what does collaboration actually look like for them? We've clustered them in 4 big groups. The first one we could look at is what we have termed home visits. And by home visits, we mean that for a number of people who come to these healing centers, or what we call prayer camps, the space there becomes a home, so to speak, for them. And therefore, the mental health workers go there in the same way they would do regular home visits in individuals' homes. They go to the camps to visit the patients at the camps, to check on them, and sometimes they go there to do assessments. When there's somebody new who has come, and some of the healers would call on them to come and do an assessment of the new service user or the patient who has come there and is requiring help. They would do an assessment and make recommendations for the treatment. They also go there to provide medication. When these assessments are done, a lot of the time they come for people who are not able to afford medication or afford the healthcare. And so most of the time when the health workers go to these prayer centers or on these home visits, they provide some medication and other supports for them. They're also the ones who often would do some mediation with the healers in terms of minimizing the use of chains, in terms of encouraging the absence or minimizing their use of forced fasting and things like that. They do a lot of mediation, even with families or caregivers who are at the camps with their loved ones. They would also do some, they may sometimes do some mediation with difficult family relationships as well. And the second broad theme is looking at the church clinics. As we saw in one of the videos, many of the health workers, the teams go to the clinic, to the churches, and organize mini clinics where they give talks, they educate healers, or they educate caregivers. They provide a space for a support group sort of system where people can talk about their troubles or their issues or and encourage each other. And when they go there, they review patients. They check on adherence to medication. They check on any potential side effects. You know, they look at whether or not their medication supply is okay and all of those things. So they review patients at the camps. And during these clinics, they may do even some physiological checks as well, not just for mental health. As we saw in the video, they would check things like their blood pressure and their blood sugar and things like that, just to be sure that the people who are living in these camps and seeking help from these areas, they also benefit from a biomedical intervention, even if they do not come directly to the health center. Now, the third theme is the community outreach work that the health workers do. They give a lot of talks, they do a lot of education in schools, in churches, at radio stations. They do a lot of interventions in terms of, or they do a lot of education in terms of raising awareness about mental health conditions, about treatment, about care, and all of those things. And a big aspect of their work is also fundraising. As you can see in the picture here, this is the picture up here at the top here is a picture of some of the nurses who had gone and solicited not just funds, but also items to provide bedding, to provide clothing, to provide all sorts of materials that some of their clients may require and are not able to afford. Employment issues are a big problem with certain classes of people who have lived experience of mental illness. And so these health workers fill a certain gap by helping them to settle a bit after when they are in recovery, by mediating with family members to help them to start a business or to go to school or whatever it is that the person desires or requires. The mental health nurses do a lot of outreach within these communities to teach and to encourage people to show, to help out or support their loved ones. And the last aspect is referrals. The healers refer people who come to their centers to the health workers. As one of the healers said in the video that we watched, when the person arrives, one of the first things they do is to ask them to go to the health center to see the nurses. Many of these people come from communities, not necessarily where the prayer camp or the healing center is located. They may have traveled from other places to come and seek help there. So when they get there, the healers that our health workers have partnered with would send them to the health center to get an assessment done properly. And because of the collaboration that has been built, to a large extent, many of them would also then continue to monitor the treatment that has been prescribed by from the health center. And then on the other way, when they're on their way out, the healers that we were able to see, some of them would send the clients back to the health center to let them know that they were leaving, to let them know that they're in recovery. And then the health workers or the nurses to the communities where they came from initially. So the referrals from the healers to them, and when they're on their way back as well, they refer to other facilities which are closer to the patient's communities. Okay, now the third thing I want to discuss is what makes this collaboration so successful. The very first thing, obviously, is the commitment, the passion, and the persistence of the teams that we saw. They have been so persistent, so committed to making sure that they work together with the healers to ensure that the patient's outcomes are better. Many of them told us about having to go multiple times. You go there, you start building the rapport, you go, you make friends with them, you go, you explain things. So you need to go there often. You need to be persistent and committed to building that relationship. And when the healers feel that you respect them and you respect their authority, you are not there to condemn what they do. Because from what we have heard in other places, the previous history is that many healers feel as though biomedical sciences look down upon them or they disparage their practices. And therefore, some of them may be a bit resistant at the beginning, but we've seen a team that has been very committed and has persisted in going on over and over again to ensure this discussion or this collaboration happens. They have gotten institutional support from what we saw in the film. Some of them have gotten institutional support from the Municipal Health Directorate, and those things help to make the journey a bit easier. The other side of it is the attitude of seeing themselves as partners with healers. When the healers and health workers saw themselves as partners, it meant that they looked at it as a mutual beneficial relationship. And therefore, one of the quotes, for instance, says that whatever I do will be to your glory as well. And so they are not there, they emphasize that they are not there to take over anything or take anything from anyone, but to work together with them. Now, just briefly about, I'm going to skip these two because of the timing, but just briefly about the challenges that some of them have experienced. The big one is about resources. Mental health is still not a big priority in most of our contexts, and therefore resources are very scarce in terms of supporting the work that the mental health workers do. It is getting better, but it's not where we need it to be quite yet. So there are very limited funds. And some of the communities that our health workers need to work at or they need to travel to, they are quite far, the roads are bad, or sometimes they need to travel in the middle of the night when there's an emergency situation. And if they do not have access to vehicles, even motorbikes for some people are difficult to come by in some communities. And so the resource limitations is a big problem. Sometimes they're able to access these places, but then the supply of medication is also a problem. When the mental health, the medical stores do not provide medications that they can give to clients, then even when they're able to get to them, they're not able to support them with the medications that they need. So resources are very much still a problem, although we are seeing some transformation. Well, each time there's something better, but we are not quite where we need to be yet. One of the other things was the suspicion about intentions when they are building up their collaboration. As I've said before, some of the healers have a history of being disparaged or being disrespected in their views by biomedical practitioners. And so they are not so eager to collaborate with people when they feel as though they would not be treated properly. But our participants always constantly emphasize being respectful, making sure that you show them the due respect and authority that they hold within the community or within that space that they're in. And then that helps to smoothen the path for the collaborations to take hold. Then lastly, it's the issue of challenging the use of chains. We see them negotiating with the healers not to use the chains and all, but one of the big problems with that is, again, limited resources. We do not have many inpatient facilities or inpatient spaces within many of the regions in Ghana. And therefore, when people go to the healing centers and the mental health nurses are negotiating for care, for better care, it is also within a space of recognizing that there are limits on what they can actually provide. And therefore, sometimes they may need to be a bit more creative in the ways that they can negotiate the use of things like chains. In as much as they disagree with it, it has to be a careful process, because when the other side of the matter is brought to them, there's very little that they're able to do for a large number of people. So these are some of the challenges that our participants shared with us, or some of the things that we identified while we were following them for this film. But generally, we found these two teams to be such committed and dedicated teams that they think so much outside of the box on ways in which they can make the lives of their participants, their clients, and the healers better, and how they can work much better with them despite the limitations that they've experienced. So in terms of next steps, I know Esla will talk a little bit more about the implications and stuff, but we are looking to do the participatory videos if COVID allows us. And then we'll also be doing some more dissemination with the videos, the final cuts of the videos. Thank you so much for being here with us and for your time. And we hope you enjoy this.
Okay, thank you very much. Thank you very much, Lily and Ursula. So I think it's now time for question and answers. Of course, there are a lot of things and inspiration that come out from the two presentations. So I maybe expect that people are asking for questions, and also I will ask the presenters to reply, and including the whole team. So if there is some questions, we can start. I think we have no more than a quarter because we are running out of time. Unfortunately, there are some delays. So maybe Wulan has collected some questions. In the meanwhile, I can start very quickly, because I think it's an enormous amount of questions that have been raised by for me, for the first one is that the simplistic view that task shifting is the usual way of describing the problem of resources in low and medium income countries, particularly in low income countries. But I think this is much more than task shifting. This is about integrating and creating a system which includes several components. So I think it's an issue of not just of integration, but negotiation and mediation, recognition of the resources which are provided by the community and the culture. So what is the relationship between the individuals and the community? And in your opinion, what can be the role of the culture, including religion, as opposed to medical knowledge somehow? So I think these are seems to me to be the two poles. One, the individuals, and sometimes the individuals are powerless, they are disempowered, as usual in psychiatry, in Western countries too, particularly in the age of the asylums. Today, maybe a little bit less, just a little bit. So the issue of empowerment is one of those, and the relationship between individuals and communities, because in this interaction, there will be a lot of the problems related to psychiatry, madness, and recovery. So I think these are some of the questions for me. So and more beyond that, the production of meaning in this action, which is another important issue. So I don't know if Herminia, maybe, or Ursula, or Diana would like to comment, or Lily.
Lily, I wonder if you'd like to say something about the Ghanaian context, perhaps, in response to that.
Yes, okay. Yeah, thank you so much for those questions, Roberto. And it's a lot to think about, definitely. And as you mentioned, I think there is no one like neat one size fits all kind of approach from what we are seeing or what we are experiencing. And what we are finding in Ghana also is that what is expected to be the case and what happens on the ground makes such a big difference to the actual experiences that people have, both on the side of the service users and the service providers. And in as much as there are strides being made, we're still seeing situations where the health workers would have to sort of put themselves into the mix in order to be able to provide some care or some intervention based on the resources that they have available. It makes it sometimes difficult to what's the word? To sort of streamline what the actual situation is. And I think maybe that's some of the difficulties that we have had, at least from my experience here is about what is the right way or right approach, which then considers everybody's perspectives. I find that within the settings, if considering what we have seen with the groups that we've worked with, allowing the teams to also have a voice, so to speak, or to share in the production of what their needs are, letting them also determine how they can fit into what the so-called national policy or national ideas about access and about services is important from what I have seen. Within those communities, their approaches were slightly different, but then they seem to achieve the same ends because they had taken charge of what needed to be done and were approaching it in that way. I don't know whether I've answered the question. There's still quite a lot to sort of digest from your questions, but these are some of my initial thoughts. Yeah.
Thank you very much.
I don't know whether Ursula can chip in.
Other comments?
Thanks a lot, Lily. Sorry, Roberto. Yeah. I suppose I think the very important new question you asked, which was about the question of disempowerment, and I think that's still very much a a relevant issue, I would say, in relation to how decisions get made around where people receive care, how that care is carried out. And yes, I think in our research, it was very clear that really the individual who was affected by the mental health condition had the least status in making those kind of decisions, that predominantly families and healers. And so that I think is still something that very much needs to be taken forward, and that I will be mentioning in my presentation. But yeah, thanks a lot for those really helpful comments and questions.
Okay. Okay, there is a question from the public, I think, which is about how the team will do the dissemination of the study result. I think this is a key issue. Who would like to reply?
I can start maybe. So as I was mentioned at the beginning of the presentation, there is different kind of outputs of the project, and they will be disseminated quite differently. Some of them will be through film festivals where we're hoping to go, and conferences and more traditional lectures and seminars. But what we're hoping is to do a lot of community kind of based work as well. So we were planning to go back to Ghana, and now because of COVID, we will be going to Ghana later, and that also will mean that we hopefully will be able to do more community-based screening as well, directly in the country as well as in Indonesia. Hopefully in July, we're organizing an event in Indonesia. We try to bring together actually some of the healers and the mental health professionals we'll be working with to be together, some of them in a place, and be able to discuss together, to be able to encounter each other, but also be able then to go back to Indonesia in the field sites and presenting what we found back to the community. But also and also I was going to be talking shortly about the implication of the study. So obviously we realize there is different audiences we need to be able to reach, to be able to see the changes we want to see. And I mean, I'm a teacher, as many of you probably are, so I know that starting from university, after this presentation, Lily and I are doing a talk to my students in psychology in London about politics and identity, try to see psychology as a discipline, which also has a political role, and what actually is a role as an activist. So I think sometimes be able to also start in schools at every level to see people, understand people, we all are part of change, we are all social agent of change, and we can make these changes ourselves, and try to bring that kind of knowledge at every level. I work in my niece with a teenager and now with our students later on, and so try to take some of the learning to the students in many different kind of mental health disciplines, and also outside of mental health. I think it's a very key role about to be able to implement some of these changes and policy. So we want to reach, of course, the policymakers and stakeholders who make decision, and where you're saying where usually people who have mental health issues are seen in a passive role, to be able to actually give a much more active role in terms of sharing the learnings, sharing what we have learned through the fantastic mental health professionals and healers we've been working with, and taking these changes where this knowledge where then decisions are be taken. These are some of the ideas, but I think Ursula, because we're going to be talking shortly about implications of the study, and we'll be prompting you all to give us idea about what can you do to help us to implement these changes, and what can we all learn from you in terms of thinking beyond what you're already planning now. And we really see the title of our project is Together for Mental Health for a reason. And when we mean together, we don't mean only our team. We are very solid team. We have a fantastic, as mentioned, advisory groups, steering committee, participants. Some of them actually in the project are still now in the chat with us. So we are already a big group, but we want to be expanding and making the kind of changes we need to make. So we want to be in this together with all of you and the people you are connected to. So help us to be able to make these changes.
Thank you very much.
Yeah, maybe I add a bit, as well as, we are in the Center for Public Mental Health. Advocacy is our middle name. So we will do lots of things to disseminate this, but the purpose is, the main goal is the advocacy, to introduce how to empower the faith-based healer, traditional healer in the mental health system in Indonesia. And we will the planning is that we will have a summer course dedicated. So we are actually having summer course regularly yearly, but we plan next year to have a dedicated one series regarding this, and we do hope that we can make the people from the Ministry of Health or from the government sitting together with the spiritual healer. So what we do can be discussed directly in that kind of event. That's the biggest one. But the other thing is, yeah, we disseminate through our student, through our webinar, yeah, things like that. And we learn from our research that basically most of Indonesian are spiritual. So basically, if we are empowering spiritual healer, it will be very strategic way to address mental health issues. Thank you, Roberto.
I also wanted to chip in that we've also started looking at, I bet Esla may talk about it briefly, about how to use the film in what we are calling community conversations around mental health. And so going to communities around the country to discuss what the findings are from the film, and using that to initiate a conversation about what the mental health situation is, what could be done differently, what are their experiences or their perspectives on what mental health processes are in the country. So looking at, we are hoping to use that as a way of taking it out of only the academic space, because in much of the rural parts of Ghana, there may not be people who can access YouTube videos on this film and things like that. So we are looking at how we can get to them as well to get some interaction or some feedback from there as well.
Thank you very much. I think, okay, someone raised the hand. So I think we are going more and more into an issue of complexity. So I think for all of us, including starting from me, we are just starting to wonder very basic issues. What is mental health care? What does it mean to have a recovery? What is a treatment? So, so this is very much important to recognize how the complexity can be raised by these views that go really into the culture of communities rather than overimposing a medical model or a globalized approach to mental health care, which is one of the critical points for the global mental health movement. So which is not just applying, for instance, mental health gap, but mental health gap is one of the tools, of the many, many tools that are useful to create a program for that particular individual, which requires a lot of other ingredients related to his social context, cultural context, community, etc. So I think about the questions, maybe someone raised their hand. I don't know who would like to. Yeah.
Okay. There was, I think Stephen, I do actually know this person. So Stephen, do you want to ask your question?
Open the microphone, please.
Or type in the chat as well.
Can you hear me?
Oh, yes.
Oh, yeah, I finally got it. Sorry. Yeah, I was gonna. Thanks very, very much for the presentation. It's quite. I find it quite full and quite comprehensive, and thank you very much for that. My name is Steve. I actually work as a social worker and an approved mental health professional in London, and I've been doing so for many years. And my understanding from both presentations is that looking at collaboration from a least restrictive perspective and the partnerships that you actually form with informal carers and traditional healers and also primary health providers. That's my understanding from both presentations. But when you were talking that, at what stage do you find that this form of collaboration doesn't work? Does it ever break down? Do you have to go back again and reorganize your consultation or the collaboration, or at what point do you completely disregard the collaboration? Because one of the objectives of the study is actually also looking at human rights abuses, coercion, and restriction. I sometimes find that some of these informal or secondary sort of like providers, traditional healers, may also be breaching the human rights practices, the universal human rights practices. So what point do this collaboration becomes disentangled, disorganized, unsystematic, and not in the interest of the service user, the families, or the community? It was all good what was presented. I saw it from a positive angle, but I didn't see the other side of it in both presentations. Yeah. Is this anything you can clarify for me?
Thanks a lot.
Yeah.
Someone would like to reply to Steve?
Yeah, I could. I think. Did you want to say something, Lily? Oh.
Yes, I could. I could explain a bit more. One of our limitations that we do acknowledge is the fact that we worked with teams that had successful collaborations in place, and one of the reasons for that was because we wanted to see what it actually looked like, and we did try to work with health workers who were now going to establish collaborations with some healers so that we could get an idea of what it was like, but it didn't quite work out for a number of reasons, and issues of our time, the time that we had available, and a number of other things that were going on. But as I mentioned in my presentation, it took persistence from what the health workers told us. It takes persistence, and there were actually some people who, at the time we went, they were still negotiating with, they were still working with, they were still discussing collaborations with. There was one person who eventually dropped out of the study, and he was one of those that they considered a bit difficult to work with, because they had been going to him and discussing with him and all of that. The main thing that I think that the teams are careful about is to be sure that they're working on a partnership with them. I always refer to this as a really interesting paper by a young Ghanaian who says that whether we like it or not, people are going to them. We've tried clamping them down. We've tried demonizing what they do. There have been a number of things that had been put in place or tried, which sought to shut them down. But the reality is that we do not have a lot of mental health professionals within the system, that if these places were non-existent, we would be able to provide care. So the teams have been careful about negotiating with them, partnering with them, working with them in a manner that is mutually beneficial. They kept emphasizing that we do not need to sideline them. We just want to work with them so that we can then minimize these human rights abuses and maybe actually even get rid of them completely, so that we can regulate better what they're doing, what they're providing for the patients, and so that we can develop a pathway of care where even if people do prefer to go to get some aspect of spiritual kind of care, which is within their rights to get, they would also not be denied other biomedical processes that they can access to get better as well. So it's about forming that link, forming that partnership, and making sure that we're working within the systems that people choose to go to, and making sure that it is working properly and not abusing anybody's human rights. It isn't perfect yet. As we said, it is fairly new. This commitment by the Mental Health Authority to collaborate with healers is fairly new. And we know that there are communities where it isn't working as well as in the ones that we showed. But we thought these two places that we showed on the Ghana side, and I know it is similar in the Indonesian side as well, they showed what is actually happening. They showed the challenges as well, but they also showed what can be really good about working with these healers.
Hey, thank you very much. I have a question about this point, sorry, before closing this part of our meeting. I suspect that Pasung is not a treatment, is the failure of a treatment. It's the same dynamic that can happen in Western medicine, in Western psychiatry, about the use of asylums, for instance, or the use of restraint in the Western medicine and psychiatry. So it's when you conceive that this problematic thing, which is mental suffering or madness, can be just resolved with a simplistic approach, like a problem with a solution. But there are no solutions, not easy solutions. So it's just talking about a pathway of recovery, which includes a number of individual and social issues, etc. So if you think in a simplistic way, okay, people using their effort, like traditional healers, to cure people, but when they are not able to cure, they use Pasung as a residual of their treatment, as well as we used asylums as the residual of psychiatry in the Western world. So I think maybe it's interesting to see how your first results are showing that it's more important to create a more complex interaction and a network of opportunities where the person can go through and the family and the carers together. So not just a simple solution. I don't know if I'm wrong, probably, but this is my impression. Okay. No
if
comment.
I may add from an Indonesian perspective about whether or not a collaboration is always successful or not successful, and probably repeating what Lily has explained, that this is rather a purposive sampling method, that we are trying to have lessons learned from those that have collaborated in a rather more positive way. But it's also highlighting what will not work because of the absence of these factors that will help collaboration. And what we have found, one of the things is whether or not from these intermedical interactions from different medical healing perspectives, if there is a safe space to be vulnerable to each other in a way, to be able to talk about what their views are in a way that is not seen as threatening to each other. And this also relates to what really works is because of, at the end of the day, it is also interpersonal relations that is built between all of these actors. And this sustainability is what will then return again to create safe space for a longer term. And there's no feeling of threat. And this also then relates to how they relate to the either clients or patients that they work with. And it's less transactional kind of interaction. It's more like there's a what some people probably call moral economy. So there's like a continuation of relationship there. I might be wrong again. Probably someone can add on that. Thank you.
Thank you very much, Adi. I think it's about creating micro systems of care, holistic around single individuals. Okay, thank you very much. I think we have to go on, and so I ask Ursula to comment about the implications of the films. And there is also a question linked maybe to that from the public. How can you follow the results from this and future events? Thank you. Ursula.
Thank you very much, Roberto. Yeah, I'm going to sort of whiz through a very quick sort of presentation, really just summing up that what we've been talking about, and then we will close with a discussion about how we can use the films and what next. So that will be open to everybody. So I'm going to share my screen. I will not mute myself this time and just whiz through. So yeah, okay. Is that okay?
Yes.
Okay, great. Thanks, Lily. So what are the implications? I'm going to whiz through very, very quickly because this idea of collaborating with traditional healers has an extremely long history going back to the colonial period, and Asti and I had a very interesting conversation about the different histories between Ghana and Indonesia in terms of how this has influenced these attempts at collaboration. Then from the colonial era, moving to the period of transcultural psychiatry in the 50s, where there were these studies of traditional healing and the critique of psychiatric universalism. And then these early post-colonial experiments with collaboration. A famous example in West Africa was Thomas Lambo in Nigeria, who worked with traditional healers there. And then these attempts at regulation and professionalization. So we can see that a lot of these movements towards integrating traditional and faith healing into mental health care have this very long genealogy. In Alma-Ata, which was the declaration around primary care, also included this idea of integrating traditional and faith healers into providing health services at the community level. And if we look at the WHO traditional medicine strategy, which was published in 2014, it's still operational, this very much also includes this idea of integrating traditional healing into the healthcare system. And in global mental health, this idea has again been revisited, as Roberto was saying, around task shifting to traditional and faith-based healers as ways of filling the treatment gap, scaling up mental health care in terms of their sustainable development goals. They also talk about harnessing the contribution of traditional healers as part of meeting the goal for universal health coverage. And then WHO also promotes the regulation, research and integration into the health system, which is what we see very much in Ghana. They have these guidelines and protocols for regulating traditional and faith healers, as Lily was explaining in the new Mental Health Act. And in Indonesia, they have their Free Pasung program. So, of course, as we've mentioned, there are the ongoing human rights concerns, and lest we get too, we don't want to overlook this as still being a grave concern that was recently highlighted in this Human Rights Watch report, which did include case studies from Ghana and Indonesia. And so it does underlie, again, the importance of finding where these collaborations have worked to help reduce some of these human rights abuses. But if you look on a global scale, actually, the extent to which these collaborations are formally taking place, it's actually quite small. In the WHO, in the latest Mental Health Atlas, it's only 12% of countries were reporting that they were doing this form of collaboration. But I would suggest that under the radar, these kind of informal collaborations are probably much more widespread. But as we know, there have been a lot of critical perspectives on collaboration. Lily and others have written about these power differentials between the different healers and health systems. Psychiatry is often the unmarked category, so it's supported by public health systems and global health and development, whereas traditional and faith healers are not. So education, scrutiny and regulation tends to go primarily from the health system to the healers and not the other way around. And as Roberto was hinting at, collaboration can result in the exchange of one form of coercion for another, so chemical restraint rather than physical restraint. And that is often the way that many health workers do work. And in the process, spiritual and ritual approaches and practices may be effaced, devalued or distorted. And this is despite us knowing that these are actually very important to a lot of the people using health services themselves. So the complexity which we've hinted at and which our research clearly shows may conflict with the need for a kind of portable, scalable technique or a model that can just be scaled up around the world. And as Anne Lovell and others have written about, there's an incommensurability at the heart of these collaborations between the epistemologies, the ways of knowing, and the values that are embedded in these different approaches to mental health. Another major critique has been around the issue of, to what extent is this about people's beliefs or about people making choices, or is it about structural violence? So is it about the fact that, as Lily was saying, there simply isn't enough there aren't enough mental health workers, there isn't enough good quality, accessible, affordable healthcare? Are people using traditional faith healers to make up for deficits in health service funding? And I think certainly in the context of Ghana, there could be an argument that actually a lot of the kind of containment, confinement, restraint is being pushed onto traditional and faith healers, because there are only three inpatient psychiatric hospitals that offer kind of crisis care. So it could be what Sen and his colleagues have called a forced pluralism resulting from inequality. But what we've seen is in our research really is the pragmatics that mark these kind of collaborations, which differ from how it's imagined in policy often. It's marked by diversity and improvisation rather than standardization. The healers and the health workers are both working with very limited resources often and without any supervision or support. So in times of crisis, they face these very difficult ethical decisions and have to negotiate these conflicting imperatives between duty and care. And traditional and faith healers are often, in these cases, the only available resource when crisis comes. And as we've mentioned throughout this afternoon, healers and health workers are members of the same community. They share a religious and a spiritual worldview. And that was very clearly articulated by the nurses that we were working with. And collaboration is worked out through and within these relationships. And it's relationships that are so crucial to making these collaborations work and negotiating around status and authority. So the success is measured through the quality and endurance of these relationships over time. So the recommendations that come from this could be about strengthening communities and working for systemic change. So I've been very much inspired by the rapporteur, he just recently left post, Dinas Puras, who's written about who was the UN rapporteur on the right to health. And so strengthening communities and working for systemic change means paying greater attention to the sociality of lived experience of mental health conditions, healing and recovery, and opening up these safe spaces, as someone was mentioning, as Asti was mentioning, for open and mutually respectful dialogue between people with lived experience, families, healers and health workers on valued forms of care. So what is valued by people with lived experience of mental health problems and their families. And that may include planning for how to respond to a crisis. So in the UK, for example, this idea of advanced directives has been one way that people have been able to state their preferences before in case of a crisis and on what kind of care they want. So moving more from an educational approach to engagement with pluralistic perspectives on mental health, distress and extraordinary experience. So not just about what we can teach you, but what we can learn together from all our different perspectives. And not just about health systems strengthening, which we hear a lot about, but strengthening social systems and communities. And taking this human rights approach, so not just focusing on coercion and restraint, which is often the focus of human rights initiatives, such as as in the Human Rights Human Rights Watch report, but also seeing human rights more broadly as being about addressing the social and structural sources of oppression, exclusion, and inequality. And we would argue that real change can't really happen at the micro level between healers and health workers and families without this more systemic change to address these inequalities. So, so that's all I really wanted to say. Thank you ever so much to everyone for listening. And as we were saying, I think somebody might have their microphone on, or there's an echo I can hear. But we wanted to move on to thinking about what suggestions people might have for how we could use the film. And I do believe that Wulan, who's our marvelous tech whiz in Indonesia, has set up a poll to just take some ideas. So I'm just going to, so we wanted to know how you think you might use the film. Obviously, when we wrote our research proposal, we made some suggestions about how we thought the films could be used for teaching and for training. So I think, Wulan, they can just copy this link and use this and use the code to access the poll. Is that right? Are you there, Wulan?
I think you just need to go to menti.com and then
so
enter the code. Yeah.
Yeah. It's all provided in the chat box. Please refer to the chat box.
Yeah. So for teaching, for training health workers, for training healers, to discuss with families, or you may have other ideas, please do write any ideas and suggestions in the chat box about how you think the films could be used and how they might be useful to you. Okay, so some people have already responded. Amazing. I mean, as Lily was saying, I think we very much, we're very keen that these films don't just remain in academic circles. We don't just want this to be an academic exercise. The whole idea behind doing it in a film format was that we get over some of the challenges of language and of accessibility to the findings. So the Ghanaian film, for example, we want to make sure that it's available in different Ghanaian languages through doing voiceover on the films. And I know in Indonesia, there's also many different languages that we would like the films to be available. So discussing with families, using for teaching, okay, great. Training health workers, training healers. So so you can keep going with that, I think. And in the interest of time, I will move on. Can we have 2 questions going at the same time, Wulan? Is that possible?
Can we maybe ask people who are writing other if they can text? It's very important for us to also think what you said beyond what we already are thinking. So it's important to see how else we can use. So people who are thinking also other platforms other than those who for one, if you can write in the chat, please.
Yes, please. That would be ever so useful. So Samba Bayu has raised his hand. Do you want to say something, Samba? No? Or is that a mistake? Anyway, if you have any suggestions, please do write in the chat box. So great. Teaching. Discuss with families. So it's great that so many people think they might be able to use the film with families. That's good to hear.
Yes, and we are receiving also other comments from the chat. Someone said, I think there should be a multifaceted approach, family healthcare workers and faith healers, as there needs to be an open discussion and also sharing with colleagues online. It can be adapted into local languages and used as a way of empowering families through various media. Also dialogue across contexts and countries, and to generate new research questions. Yeah, there are some. Yeah.
Dialogue across contexts and countries. Yeah.
Yeah.
And very, I mean, as Armenia was saying, one of our real aims, and it's just wonderful to see these conversations growing between Indonesia and Ghana, and that getting those conversations going across countries in the global south rather than being mediated by the global north is one of the legacies that we hope will come from the research. Lovely to see all the chats, yes. Amankwa, thank you. Yeah, it's just great to see everybody here. We've got people here from Ghana. We've been chatting away to our nurses who are in the film in Ghana on the chat, which is just wonderful to see. It's really great. So the second question which we asked was, could we put that up, Wulan? Is that possible?
Yes, I will. Just a moment.
Thank you very much.
Where is it?
So one of the, while Wulan's putting this up, one of the things that we suggested was that we were going to, well, we will be developing a screening guide, which will be developed for each of, for Ghana and for Indonesia, to use when, which will accompany the film. So it will be freely available for you to use when you're showing the films. And so we wanted to know what ideas you might have to include in the screening guide. So that print is so small, I can't actually, what's number, the red bar? I can't actually see that.
The red is the information on the different healing approaches.
Okay.
And the pink one is background on collaboration between traditional and faith healers.
Okay, great, excellent.
And the green one is the case studies on people using healing centers.
Yeah. And we hope that the participatory videos, all being well, we hope we can still make them in Ghana as well, and they will be excellent as kind of examples from sort of amplifying more the voices of people with lived experience of mental health conditions who've received, who've used these healers. In the larger films, there's more conversations with families and people using the healers as well. So our final, we are very much hoping that the final cuts will be ready early in the new year, and we will keep everyone posted about the launch, and we hope there will be some in-country launches as well as an online launch. So thank you everybody for participating in those polls and giving us your suggestions. And once again, anything, please do write in the box. Please email. We'd love to hear from you if you have suggestions of how we could use the films and what you would like us to put in the screening guide, and anything else. We're always welcome. We also always, it would be very good to hear your contributions and ideas. So I think I can hand over now back to Roberto.
Okay, thank you very much, Ursula. I think this was also fantastic to see this growing live. Okay, I think we are going to close this meeting. I would like just to comment that this was a great opportunity for me, and I think for the audience. I remember some of the words that I heard in the movies. For instance, someone said, we need a medium between the spiritual and the medical. I think this is one of the key issues, or talking people as brother and sister. So the very important role of self-help, or people mutual help between people. And also, it's very strange sometimes, but of course, with the highest respect for cultural diversity, but the idea that people with mental health problems can have to face with previous sins or mistakes. This is another sentence in the movie. In the first movie, it was very common before the birth of psychiatry, but still is embedded in psychiatry. So the so-called moral treatment at the beginning of psychiatry was established by in the UK by Tuke, and then later on by in France by Pinel and Esquirol and others, was related to the idea that people with mental health problems has something wrong in their lives. Of course, this was a moral judgment. We cannot accept it anymore today, but it's still very important to find a meaning. And medical models don't provide meaning per se. They need to be complemented by a more complex view, particularly taking for a multidisciplinary approach, and also using some very simple words. I heard the importance here of relationships, also from the presentation of Ursula. So how is important negotiation, sociality, dialogue, open dialogue particularly, and the shift from educational approach to engagement of people and communities, and strengthening social systems. I think these are all words that can perfectly fit in Western crisis, in the crisis of Western psychiatry today. I think we need that. We try to establish in some experience in community-based mental health care, like my personal experience in Trieste with the group of Franco Basaglia, Rotelli, and others. We try to use this very simple human means, not just to rely on complicated technologies provided by the medical knowledge, but just to work with the communities and using their resources, and particularly to combine their resources with the resources of the individuals. I think this is very much transcultural. This is not just related to diverse contexts that we don't know very much as people living in so-called high-income countries. So I think we need to recognize that this research is raising many more questions than those that can maybe resolve. But these are very good news. These are very good news. So thank you very much. I leave to Herminia for a final greetings to all people, and Ursula and the whole group. Thank you very much for me.
I think that's a beautiful note on which to close this gathering. So I will leave to the UGM to actually do the final closing goodbye as they're hosting the event. But again, my thanks to all of you, and we hope to see you again soon in our next event. We'll have the online release for the Indonesian and Ghana films. And as we were just chatting with some of our people in the film, in those events, we also would like to invite some of the people in the films, in the research, to actually be part of the discussion. As we say that this is a collaborative project, and the collaboration goes well beyond the months spent in the field work. And these are important relationships we hope to continue building. And so hopefully you can meet them, some of the people who are able and willing to participate in the next event. So you can actually ask them a directly question and also ask updates about their amazing jobs and difficult jobs they're doing in their own countries. So please follow us in our social media, in our blog, YouTube, and be part of the conversation. But more importantly, keep giving us advice. We are very open to advice and about how can we make use of what we are funding, and how can we keep learning about this complex issue, but very much timely. So thank you again to all of you, and I hope to see you soon again.
Bye.
Thank you very much, Roberto and Herminia, and everyone involved here. And so in the spirit of engagement and relationship, please also be in touch with us in all of the social media accounts that we have on Facebook, on Instagram and Twitter. And Instagram and Twitter, it will be @together4mh. And we are very, very much inviting you all for a long-term conversation about the topic. And because we start this with a moment of silence, perhaps it would be good for us to take another moment of silence to reflect on our very productive conversation today. And yeah, let's begin. And thank you for that moment. It's been lovely having you all in this platform. And of course, you all have the link to all of the YouTube and Uwistia videos. And we'll see you in another event for Together for Mental Health in Indonesia, Ghana, and the UK. Thank you, everyone. Bye.
Thank you, Roberto, so much for a fantastic sharing. Thank you.
Thank you, Roberto. Thank you, Anna, for coming.
Thank you, Anna. Yeah, it's nice to see some faces. Nice to meet. Nice to see some known faces.
Everyone, thank you.